Good
Hello,
morning.
everyone. Welcome to our talk on resident entrustment called Entrust but Verify. I'm Sarah Tomlinson, and I'm an APD in the EM and PEM fellowship programs at the University of Michigan. I'm joined by several of my colleagues today, and we hope to provide you with some excellent tips on entrustment and autonomy with your learners. We have no relevant financial disclosures. One of our presenters has a Navy disclaimer that this talk does not represent the policies of the Department of Defense or the US Navy. Our goals for this talk are to define the concept of entrustment as it applies to medical education, explain the importance of entrustment to the development of independent providers, describe barriers encountered in allowing autonomy, particularly for those who warrant less independence, and formulate and implement solutions to enable entrustment through guided scenarios. As faculty in an academic institution, we're tasked with the responsibility of preparing our residents for independent practice. But providing autonomy to residents is not an easy task and requires delicate balance. There are many factors involved. As faculty, we are all different physicians with different practice patterns and different risk tolerance. Residents themselves have different skill sets and progress at different paces. And most importantly, the need to provide safe patient care is paramount. And as if that wasn't hard enough, we know from adult learning theory that residents need autonomy. Without it, they lose the motivation to further their education and their progress towards independent practice. The concept of attendings allowing appropriate autonomy so that trainees can develop independence in their practice has been termed entrustment. And it's probably one of the most difficult things we do, but also one of the most important. The foundation of entrustment is obviously trust. We must trust that a trainee will do the right thing. Depending on their level of training, this could mean that we trust the trainee to obtain an accurate history and physical exam, or perform a procedure competently, or run a resuscitation. All of these things are pivotal steps in a resident's training towards unsupervised and independent practice. But as we said before, providing entrustment is not easy. Think about each patient as being somewhere on a spectrum of 100% the attending's patient and 100% the resident's patient. Take a moment to think about where you perceive patients to be when you're staffing residents. Where do you fall on this scale? Now think about it from the perspective of the last resident that you worked with. Where do you think they felt that patient encounter fell on the same spectrum? And is there a difference between their perception and their reality? We hope to peel back some of the layers that complicate this process of providing entrustment by first talking about the barriers to entrustment, and then some strategies and solutions for improving our ability to provide entrustment to our trainees, so as to enhance their learning experiences and get them ready for independent practice. We hope that by learning some of the qualities that factor into providing entrustment, you will be able to find some targets for your own development in this area. Now I'm going to turn it over to Dr. Mallory Davis, one of our awesome third-year residents, who's going to discuss various barriers to entrustment that we encounter in the clinical setting.
Next up, I'd like to discuss barriers to entrustment and autonomy. These barriers can be broken into those among faculty, resident, patient, and environment. For faculty, the amount of autonomy given to a resident by an attending will differ based on the attending's own confidence in their practice or experience. This will also change depending on how risk-averse an attending feels and the degree of ownership in the patient. Some attendings will allow significant autonomy in patient care with a focus on education, while others will have a more laissez-faire attitude. Resident barriers to entrustment include attendings' knowledge of resident performance. Faculty also directly observe clinically through observation and with oral presentations. This allows them to decide the level of autonomy. If a resident is unable to orally present a patient, that is often interpreted as poor clinical judgment and ground for more intensive supervision. If a resident is more assertive and confident, faculty are more likely to entrust. Another characteristic is the faculty's familiarity with and preconceived view of the resident. If the attending has experience working with the resident or has heard concerns raised in resident assessment meetings, then this will dictate how much supervision the attending will provide. If the attending does not have specific knowledge about the level of training, then the faculty will vary entrustment based on postgraduate year of training. For patient barriers, some of these are fairly obvious, such as if the patient is acutely ill, faculty are more likely to take control of patients. If patients are needing high-risk procedures such as intubation or transvenous pacemaker insertion, this will also require more intensive supervision. Patients who are socially complex will require more oversight. Patients with overly concerned parents, patients with potential for complaints from patients or family, or need for end-of-life discussions will decrease the amount of autonomy that is provided by the attending. The environment of the clinical setting can have a significant impact on the effective entrustment. If the department is very busy or has high acuity of patients, such as multiple critical patients like strokes or traumas, this can impact entrustment. For some attendings, a busy department means they allow more autonomy, but for others, it means they become more directive and assertive. Also, the higher the acuity of the patient necessitates near immediate involvement of consultants and decreases the amount of time that faculty can allow residents to make their own decisions. The skills of nursing staff can also change the entrustment of a resident. If an experienced nurse is in the room, some attendings will give more autonomy to the resident because they trust the experienced nurse will go to the attending if they have any concerns. At some hospitals, such as academic versus county hospitals, supervision can vary on the culture of supervision at the institution. Next up is Dr. Dina Kamis, a second-year medical education fellow at the University of Michigan, who will be discussing the solutions to these barriers of entrustment and autonomy.
Hi, everybody. Thanks, Mallory. As Mallory's illustrated, the list of barriers to entrustment is long and a little disheartening, unless we use it to create thoughtful solutions. Remember that we don't expect to resolve all the barriers to entrustment, as it's a moving target as learners, educators, patients, and the ED change daily, and sometimes even faster than that. We're aiming to just partially solve Rubik's Cube here. So of all the factors impacting entrustment, this is perhaps the easiest, not easy, mind you, but easiest to tackle. Of all the domains we've discussed, we have the most control and insight into our own behaviors, compared to things like the resident's year of training, acuity of the patient, or the volume of the ED, which we couldn't modify if we wanted to on one chip. So let's go back to this list. We're not going to change any of these overnight, and that's okay. Being aware of them and their impact on your learners is a huge first step. Let's talk about confidence. Try to seek out shifts or moonlighting without learners. If you don't already have any, remind yourself that you are in excellent position whose learners are very lucky to have on shift. Alternatively, you might volunteer for didactic presentations to your residents to 1, brush up on rare pathology or stay up to date on literature, and 2, build a reputation with your learners as an informed and knowledgeable attending. Hopefully this grows with time and experience, and don't be afraid to seek out more seasoned attending mentors to help you navigate this. For those with a risk-averse approach, you are my people. The goal is not to force comfort with big risks, but to find workarounds that provide you the comfort you need and residents the freedom they need. Consider hiding in plain sight, behind the curtain or just outside the patient's doorway, where you can observe interactions and discussions without getting in the resident's way. In this vein, reassure yourself that your resident is on the right track by surreptitiously verifying their work. Ask nurses, check labs and imaging via the EMR, round on your patients separate from your resident. This way you can see and know what's happening without robbing a resident's autonomy with frequent and detailed check-ins. Degree of ownership. This one's tough. There is no sense of responsibility without first feeling and knowing that the patient is yours to help or to hurt. Without that weight, learning can be stymied. So residents need to feel it. But if you essentially hog the patients, residents know the decisions aren't theirs to make. To that end, remind yourself that the patient belongs to both of you. If it's totally your patient, they may not feel any motivation to develop and declare a care plan. If it's totally their patient, then we may risk some patient safety. Another trick is to allow the resident to completely finish the patient presentation and care plan. Don't jump in the moment that you feel you've gotten a sense of the patient's problem. That's tempting, but when you do that, you circumvent the resident's thought process and learning. It's their patient in this way. And finally, personality. There's no one size fits all solution here, but you know who you are. If you tend to micromanage, or if there's a particular procedure or conversation you can't let go of, or any number of other quirks that we all have. I'm not saying anyone is as wild as Fran Fine from The Nanny, but she's my favorite TV personality, so I've included her here. So for our very active folks, try sitting. Be in the resuscitation, the trauma, the paracentesis, or whatever it is, but sit. This will help naturally quell your instinct and desire to be in the fray and doing things and making decisions that belong to your resident. It also signals trust to your resident, which is valuable for many reasons, but particularly because that alone can bolster residents to embrace that added autonomy. If you're a micromanager, choose your hills to die on wisely. No strict rule here, but it's probably not all of the hills. For the very particular among us, if you change your residence plan, be sure to reassure them that all or part of their plan is reasonable standard of care, and the changes are somewhat physician and practice dependent. Basically, differentiate between wrong or bad care and different care. Even better, try to let go and allow some variation if it's safe for the patient. So I'd like to now hand it off to the rest of our team, Haley, Daphne, and Joe, to run us through a few cases.
So our first case is about Dr. El Arabi. She's a recent EM residency graduate and a new attending in your department. Faculty have noted that Dr. El Arabi is very confident in her decision-making. Residents are unfamiliar with her because she has not worked many clinical shifts. Let's talk about the barriers this faculty presents to entrusting the trainees. Feel free to unmute yourself, speak up, or add some thoughts to the chat. We'll be monitoring it as we go through these cases. I'll give people a couple minutes to read through and think about this. So one of the things that stands out to me when I'm thinking about this situation, one, I identify with it very personally. I'm a first-year graduate and a critical care fellow who's working some shifts as an attending. And being a new grad and being new to the department can lead to some challenging situations. Mainly, I'm not familiar with residents, and so I don't know who I can feel more comfortable giving autonomy to and who I need to watch more closely. Carly added to the chat, her confidence may lead to making the decisions for the residents, and I completely agree with that. The confidence may allow the provider to feel comfortable with her decision making and let the residents explore, but it also may be a turnoff to residents to try to find their own plans as they feel that the attending's confidence doesn't allow for that wiggle room to explore the art of medicine. Other things that may go into some barriers to entrusting trainees are the environment. If the attending's not familiar with the practice environment or the system in which she's working, or if they're undergoing their observation period for a onboarding experience, they may feel that they need to exert more control over their patient encounters, and that may lead to less autonomy for the residents. It looks like there's a couple more comments in the chat. Dina added, Dina added that residents may feel like they're trying to guess her style and not be confident in their own plans. Daphne echoed the point of if she's unfamiliar with residents, she may not know how much to trust. Sarah said, as a newer attending, she finds herself more risk averse and wanting to do more workup than a resident might, for example. And then Dina also added, if she's so confident, she might need to watch out that she clearly differentiates between bad care and different care if she changes residence plans, because she might be very particular. These are all great points. Anyone else have anything to add before we move on to the next case? Okay. There we go. Okay, case number 2. Dr. Wheelo is a PGY2 in your emergency medicine program who typically performs in the bottom third of her class. She reports an excellent patient history to you, after which you agree that the patient needs a lumbar puncture. She has performed 2 lumbar punctures before, with only 1 being successful. What are potential barriers to allowing this resident to perform the LP with minimal supervision?
We have a small group with us, so if any of our attendees would like to unmic or put something in the chat, we're happy to hear it.
For this type of, excuse me, for this type of resident, I may not allow her to do it with minimal supervision. Like I might be in the room, but not gloved up or something, just so I can assist in a more like background way, but still be present.
Yeah, I think that's a great point. I think that one of the first things I take away from this case is that I don't know that I feel comfortable with this person doing this procedure independently, and I don't think it's safe for the patient. Her lack of experience in the procedure and also her reputation or prior performance evaluations contribute to that. And I think that LPs are something, most procedures, but LPs in particular, are something that give patients lots of anxiety. And having an unconfident or a learner who has not mastered a procedural skill go into a patient room to perform a procedure that comes with high anxiety is not the best practice in my mind. And I think that it's something that in this case, as Carly suggested and as Dina brought up, maybe sitting in the room rather than standing over the resident is a good way to supervise this resident while also allowing the resident to practice the procedure.
Haley, I like that because I think if you're in the room sitting and you're watching, there's no, you always have the ability to intervene if that becomes necessary. You can always stand up and ask the resident to pause or to verbally walk you through what they're doing or whatever the case may be. Whenever I do these things, I think it's going to be, especially with procedures, because when the patient's awake, which they often are for something like an LP, I always like to talk about this with residents before we go in the room so that they're aware. And I think that helps with maintaining autonomy because it helps them maintain face in front of the patient. Can you guys hear me okay? Okay. This might be, is this a little bit better? Okay. So this laptop is silly because the mic is on the bottom. So when I put it down, nobody can hear anything. So what I was saying is that it's much easier to have these conversations ahead of time, away from the patient, outside the room. That way, when you intervene, residents don't feel like you're undermining them, which can really hurt their sense of autonomy a lot in their relationship with you. And it's just much easier and less awkward all around, so that they know what language you intend to use, what sort of, will you physically stop them? Will you say something with words? Will you give them a look, preferably where the patient can't see? So, and I think that helps them remember that if you do those things in the room, you're supporting them and trying to preserve whatever amount of autonomy is appropriate instead of trying to take it away from them.
I really agree with you, Dina. I like having coming up with a signal or a code word that I use to tell the resident that I'm going to kind of step in with some information. Like, so if I feel like their approach to the LP is wrong, I'll tell them outside the room, like, if I put my hand like on your hand, or if I say, let me take a look here, that means that I want to take over or something, just as kind of like for them to be clued into the things that I'm like the ways that I would want to take over. And then the other thing I do is I say, you know, a tip that I've kind of like realize or come to, you know, acquire over the years is doing this, or like I've found that some like doing this is successful. And then maybe the tip is actually just the next step of the procedure that they seem to be like either like forgetting or not doing right. And so sometimes I'll say, you know, like one tip I have is like having the bevel up in the needle, like before I approach, or saying like 1, 2, 3 poke, because I do pediatric emergency medicine. So all of my patients have a holder. And so that helps my holder know that I'm about to like poke the baby, and they can make sure that they have a good hold. So yeah, I'm really big on that too, Dina, about like kind of using those, like, I call them like road signs, as we're going on this journey, and like this is like the road sign that you can expect to see from me.
I think that another point to bring up is that these procedural encounters are a great opportunity to do set expectations before you go in the room, as Dina and Sarah said. And also, by doing that, you can assess your learners' competence and confidence. And sometimes the discussion of autonomy and supervision changes depending on the learner's level of confidence and also their competence. So doing some just-in-time teaching, going through the steps of the procedure, talking about potential complications, the management of those complications, those kind of things can give you a good sense of where the learner is. And then you can use that to guide how much supervision you are giving to the resident in the room.
One thing I found very helpful too, as more of a learner being a resident for procedures when I've been supervised, is when the attending will actually preface in the room when we go into the room, telling the patient that, you know, this resident has done the procedure many times, but I'm just here to like support and, you know, help if any help is needed, but also like giving some extra tips so that the patient has the expectation that the attending, that supervising, will maybe be throwing in some tips here and there. So it's not halfway through the procedure where the attending is saying, oh, you should be, you know, have you thought about doing this? And the patient's like, wait, what? Why is this the first one they've done? So I think setting expectations for the resident and the attending is super helpful, but then also for the patient when you start the procedure, so that the patient knows what's kind of going on.
Yeah, I think on the chat, for those that don't have it up, Lauren Mamer had mentioned that especially for LPs, there's so many small steps like positioning, marking your site. So, you know, if the faculty is present but not gloved, they could potentially help with a couple of those steps. It might actually boost the confidence and make the individual, the trainee, a little more successful.
Yeah. And I think, Mallory, you make a good point. One of the things that I'll do is I say very clearly to patients that there's so many different stylistic techniques that can be applied to any procedure. And so that if you hear me saying, oh, do it this way or do it that way, it's not that they were doing it wrong. There are just ways that, you know, and I'll take the blame on myself. I'll say, you know, I just liked it to be done XYZ way. And so I always have my residents kind of try to incorporate those styles or those techniques. And I make sure to be very clear that there's lots and lots of ways to do it, because Mallory's exactly right. They hear that you are changing something, and the assumption is that whatever the change is, it was being done wrong, which is sometimes the case, but usually there's just a stylistic difference.
Okay, we'll move on to the next case.
All right, so we're going to shift gears a little bit. We're going to talk about resident physician Dr. Peralta. He's in his final year of training, and during your most recent shift with him, you managed a coding patient together. You noted that his care was excellent, but he often looked to you for confirmation. How can you increase his autonomy with the next code?
If any of our audience wants to
What's
speak
that?
up. Oh,
I'd say, yeah, probably put in the chat. And announce to everyone at the start that he is in charge. So again, make it known that he's the one that's running the code.
Yeah, exactly. I think, that's kind of one of those environmental factors that could be playing into this. Potentially, there's other staff, techs, nurses, members of the care team in the room that are kind of looking to you as the attending. And so making it very clear to everyone who's present that this resident is not only in charge, but is competent to be in charge. What do you guys think about addressing potential like resident concerns for this case?
So I feel that I've had this sort of situation come up a lot. I'm very grateful and lucky to have very talented, very good residents at University of Michigan, and occasionally they don't realize they're so good. So one of the things that I'll do before is that I'll let them know that I'm always there and that I'm watching, and that if I see something wrong, I'll step in, and if they need help, I'm right there. And sometimes if they know that I will step in if it needs to happen, and they will look to me a little bit less because they'll know that I'll step in if it's necessary. If it's sort of after the fact, that's a great time to say you did all the right things. I did not add a whole lot. You were running the show. You did a great job. And I think reminding the residents that that was well done is very important so that they can carry that into the next code. As a culture, medicine is very good about pointing out when you've done something wrong. We're very good at that. And sometimes we're not that great at pointing out when somebody's doing something well. So that's something I would do there, is to just remind them that this was a success. Just like Lauren mentioned earlier with the LP, if they have a success and they feel that they did a great job, I think that's probably the best way to bolster their confidence. This is a little less black and white compared to an LP. You may need to tell them that, even if the patient has a poor outcome, that doesn't mean the code was run wrong or not done well.
I think that's a great point. I know we're talking about entrustment today, right? But this resident needs kind of immediate feedback after that code, that not only were they doing all the things right, but that in a future code, they could be more confident. So that would help to kind of bolster their confidence, which is, I think what Dr. Tomlinson said in the chat, like a good debrief in the moment. And then as Dr. Kames was talking about kind of future things you could do, distance yourself from the code. So, depending on the layout of your emergency department, potentially you could tell the resident ahead of time, you're going to be outside the door or behind the curtain or in some way, monitoring the code so that it's delivered or carried out in a safe fashion while you're still allowing them to really kind of take the lead and be that point person. Another comment in the chat is that the debrief should occur every time so that no learner or staff assumes debriefs are a bad thing. So absolutely, another plug for debriefing after these cases. Any thoughts about the faculty factors that may come into play in this case? One of the things I identified is, the faculty in this case, the resident is continuing to look to them for approval. And so potentially like doing some self-reflection, maybe there's something that you as a faculty member are doing that is inadvertently conveying to this resident that they need, your approval before making decisions or running this code. So certainly the resident could be more confident, but also you as a faculty could potentially give them that space to feel like they're able to do that.
I think to echo what Dina said too, if the faculty and the attending is often speaking and giving direction to the nurses, then I think as the resident sometimes feel like it's not your place to speak, even though it is, your resuscitation and your case to run. And I think that can sometimes be difficult as a resident to, if the attending is always directing and speaking to the nurses and giving orders, it's sometimes difficult as a resident to step in and be like, oh, well, what about this? Or because you feel like you're often kind of battling for a position of authority, and the attending obviously has the final say and is the one that is in charge.
And Lauren Mamer added into the chat that sometimes faculty are directly approached by nursing and may need to actively redirect to the resident. I think easy things like saying, when you're asked a question saying, oh, this is Dr. So-and-so's, Dr. Santiago's decision or Dr. Peralta's decision, that is a great way to defer while still being there to oversee.
Yeah, absolutely. And so I had one more comment that I forgot now. Sorry, guys.
Sometimes I will like stand next to the resident and I'll like kind of whisper in their ear like, you're doing a great job, you're making all the right decisions, which I think is like and like I do it to try and like help increase their confidence like in the moment, and hopefully like make them feel more comfortable about their decisions. And so like I think in this case I would probably say like something like, you know what you're doing, like you're making all the right calls, you're doing, you know, like you're like, you don't need me here, I'm just here because I'm here, you know. And so I think sometimes that's like what I'll do like with residents who are kind of in their, or fellows in their last year of training, is just kind of say, I'm just standing here, but you're like doing everything right in the moment.
Absolutely. I think that kind of gets to some of the positioning that you may optimize in the room. So if you kind of maintain that, you know, foot of the bed position where you're, you know, in charge, that people are going to naturally look to you because that's how we train. And so putting the resident in that position. There's another comment in the chat that I always stand with my hands or my arms crossed. So it's a physical reminder to kind of stay back and not be as involved. And so I think that's another great a great tip, especially if you as a faculty have trouble stepping back and, you know, giving the resident a little bit more autonomy. And then another comment here, one tough thing is young attendings. We want to be autonomous and independent just as much as a senior resident. So that's a conflict of interest. Being faculty doesn't mean suddenly that we don't care about running the show or intubating. So absolutely. So sometimes these cases are fun. I mean, it's part of what draws us all into emergency medicine. And so you want to be there making decisions. And it is hard sometimes to give that extra time to allow a trainee to get to the same decision. Because when you know what you want to do, especially in a high stress situation, that waiting a few seconds feels like an eternity. All right, I think we can move on to the final case if there are no other questions.
Yeah, so the fourth case. So the resident physician, Dr. Santiago, is a mid-year intern with whom you've never worked with before. She confidently states that she has performed many paracentesis as a student and is comfortable performing this procedure on your shared patient, unsupervised. So how can you best and most safely provide her some degree of autonomy? So again, I think, you know, we talked about a couple different times, you know, there's the physician side of things, there's the resident side of things, there's the, you know, the environmental side of things. So how, as the physician, can you, you know, support the intern, but at the same time make sure things are done safely?
Do we have any audience who would like to chime in?
So one thing I think that's come up a couple of times is, at least when the LP we talked about it, is kind of walking through the procedure. So that's one thing, again, you can do, you know, before the student even goes, or the resident even goes into the room, is have them walk you through how to perform the procedure so that you can get an idea of, you know, their knowledge of the procedure. Are there other ways as the physician you could, again, be supportive, but making sure the patient is done safely? So comment seems somewhat overconfident for a student. Again, this is an intern. So it'd give me pause. For this, I would have to be in the room, confident, and probably could do great, but I've never worked with her and she's too new to have been vetted by my colleagues. There's an opportunity to ask this resident to tell you all the steps and complications to assess. We kind of talked about that. So again, there's that physician side of things. And again, you know, you've never worked with this individual. They're only a mid-intern. So, you know, depending on what shop you are, they may have only done 1 or 2 rotations in the ED. A lot of their time may have been outside of the department. So again, it's tough to assess what their knowledge and skill is. Is it opportunity to, so here, but if he walks me through it correctly, I might not glove up. So again, just like we talked about before, being in the room. Someone else mentioned I'd be in the room for any intern for this type of invasive procedure. So it's not personal, it's just an intern thing, but agree, may not club up for the procedure. So again, I think it's kind of setting that expectation early on, so if they walk you through it, they know what they're doing. Just say, you're an intern, this is your first year. We really need to watch you do this procedure. So you're going to be in the room. Someone says, you'll be there as their assistant. So again, let them really run the procedure. That way you can also give them tips and tricks, like different ways to use the ultrasound as a way to supervise under the guise of giving different teaching points. So I think another way of, again, being supportive, and again, it's kind of brought up with, when you're an intern is, like our residents all need to be signed off on procedures. They need to be actually evaluated on procedures. So that's another way that you can say, like, oh, I'm sure you can do this and know how to do it, but we need to sign you off. So we need to actually directly observe you doing the procedure. So it's another way of, giving them some autonomy and kind of relying, let's say, a little bit more on like the environment and saying, either, hey, you're an intern, we have to watch you, or hey, we need to sign you off on this. So instead, also now with seeing documentation, anyone feel like I have to be in the room at some point now for all procedures. So it's not like your attestation is lying. I think that's for being present for the key portions of the procedure when we need to document that. So sorry, anyone feel like they have to be in the room? Someone said this is a senior round. Faculty still come in to me that can carry a feeling of increased gravity, higher stakes. Yeah, and I think depending on the procedure, the documentation of being present for the key portions, I think some people will say, well, I'm in the department, so does that mean I'm present for the key portions? But again, that is a way of, again, still supporting the resident, not kind of taking away their autonomy, but still being there if they need any help. Any thoughts by anybody?
And does anyone have any other struggles that they run into with entrusting residents, or tips that they have that they'd like to share with having these discussions with residents, or making these decisions about entrusting residents?
What do you suggest for a resident who has maybe already done a procedure without notifying you ahead of time?
As in, like, they have, they're notifying you that they've already done the procedure, like, oh, there was this like reduction, so I just did it or something. Or are they telling you like they're just gonna do it?
Yeah, or like a paracentesis, or nothing super, like not intubation or anything, but like some of those moderate procedures. Have you ever encountered where they have just automatically done it and then notify you after the fact?
I think that's a way of debriefing is, especially if they've already done it. I mean, it's kind of like the proverbial cat's out of the bag. So I think discussing with them, hey, we really need to be there for these procedures. We need to be there. Again, you can talk about it being billing. You can talk about it being, signing off on these procedures. And then, if it's, depending on the size of the issue and the procedure, maybe it is going and talking to the program director, leadership about, hey, this person may have kind of overstepped their bounds a little bit. Just so that they're, kind of gets reinforced as, did it happen just for you, or has it happened multiple times? Other set thoughts.
I find that this is most likely to happen with my most senior residents because they're very confident and they are ready to be on their own and independent, which is a little bit of a double-edged sword because they still technically have to have supervision. When I work with senior residents, and especially with senior, as you get to know your residents, they'll have their quirks, their preferences, their styles, and as you get to know them, there's probably a few you could think of at your shop, wherever you are, that probably need this expectation set ahead of time more than others. And so when I work with a resident who I think would benefit from that expectation setting, and I try to just make it a rule so I don't forget. I always say at the beginning of shift, I know that you can do all these things. I need to be there. It will be a problem if you complete a procedure without letting me know ahead of time. And I just say it before it's happened, and then there's no accusation. There's no room for misunderstandings. There's no well, I guess if they do it anyway, then it's uncomfortable. But there's less of that happening because they know clearly that you expect to be notified. And I'll say it's not that I necessarily need to be there the whole time or that I'll change your plan, etc. I just need to know about it before we do these things. You need to notify me. And then I try to reassure them. And then when the first one happens, I like to reassure them by maintaining that hands-off approach, even though they've notified me. So I don't want them to feel like, oh, well, I told her and then she took over. And they feel a little bit burned by it. So I try to be very careful about demonstrating very clearly that, yes, you notified me and I appreciate that. I will not, punish you now by taking over or taking this away from you. They think that there are probably residents who are more prone to that than others. Getting to know your residents is probably the biggest benefit in doing all of this, because some will need warnings, some will need expectation setting, some will need extra encouragement, extra reassurance, that sort of stuff, and you'll know who they are as you work with them.
It looks like Daphne added into the chat that she does something similar at the beginning of shift. She reminds the seniors of her preferences in terms of supervising procedures and ultrasounds. And the only thing I'd like to add is that I would just echo what Joe said about having an immediate debrief. I think that if the resident has done something that's completely out of the expectations of what a resident is allowed to do, and like doing a procedure without you even being aware that it was happening is, in my mind, in that setting, I think having a very calm but like frank discussion of, hey, this happened, it's done, but it should not happen again. And say, I would like to know when you're doing a procedure so I can pop in, use billing, whatever as your excuse, or patient safety, just like you need to know you're the attending. And when they graduate, they don't have to have someone there for their procedures. But having that immediate debrief so expectations are then set going forward is important.
I'd say, and then I think adding to that, as people are talking, I'm thinking like, but you also kind of need to know yourself. What I mean by that is if you hear about it and you need that time to walk away and kind of, so you're not creating a scene. I think it's something else to think about, because I've half had it and someone has said something like, okay, and walk away, and maybe at the end of the shift kind of try to pull them aside and discuss that about them, or about what happened, because you also don't want to yell at them, raise your voice, so that way creating a scene, or again potentially destroying their own sense of autonomy by now everybody knows that they did something that they shouldn't have, or something like that. So again, making sure that you're may need to go to a different area where it's a little more private too. So does anybody work at a shop where you do need to, I mean, some people said for billing, but you do need to be like in the room for all procedures? Or is there like certain ones like lock repairs you don't, but anything more invasive you do?
At our place, I think every person kind of interprets it differently. And so some people are not comfortable saying they were present when they weren't present, but it's not feasible to really be in every single procedure sometimes. So I think there's some variation. I don't think we have like a specific rule.
Ours is pretty much up to the attending on as well, their preference for physically being there, during what those key portions are. And whether that gets delegated to potentially a senior resident who is signed off, so can take would be able to do it independently, but then takes a junior learner through that case.
My comment kind of was about, I just hope that patients don't start complaining that there wasn't an attending in the room, and then, you know, how they perceive that present for the procedure comment. Hopefully that doesn't become an issue as we go along with the documentation.
I think it's hard because what is documented is that attendings were there for the key portions, and I don't know that patients would be able to interpret the key portions. Like some people may interpret that key portion as like, we talked through the case, the resident knew what they were doing. And other people may interpret it as like, when the needle goes in the skin, you need to be in the room. So.
There's another scenario in the chat, everyone, from Julia that says, what about the unconfident, more senior resident who gives up too quickly? How do you encourage them and not take over?
Probably for me, the best time to start would be checking their comfort before we do anything. If it's sounds like this question would be probably most relevant with a procedure or a code or resuscitation. Again, it does help if you sort of know that this is a resident who struggles with this a little bit, and you can sort of lay out the groundwork before we go into these things. For codes and resuscitations, I don't have time, so I always do this at the beginning of the shift to ward off the bad juju that comes with being unprepared and having never mentioned it. But for right before a procedure, if you know that this is a resident who has this, you can, I would start with things that maybe I would do with more junior learners. You know, walk me through the steps. What would you do? What would you take out of the kit next? Indications, contraindications. What are some common pitfalls, things like that, and try to bolster them from that that perspective to remind them that they do know these things. Now, if they're not confident because there's a complete lack in knowledge base, that probably is a little fix in one shift. But if the problem is that they do know these things, they're just not confident, then those things can be great ways to remind them that they do know what they're doing. And again, hashing all this out before you go in the room and saying that they clearly know what they're doing, they know what they're talking about, and you intend not to intervene, and you will not be gloved. I've had attendings, because I was this resident briefly in residency, and I had an attending who said, I'm not coming in there. I'll be in the doorway. You don't need me. And I hit a roadblock, and he actually refused to come in. And it forced me to try a little harder because I couldn't sit there with a needle in this patient's back and not keep working on it. So, and that was very helpful for me. I didn't feel like there was no support and that I was left on my own in a negative way, but that he really just kind of refused to let me be in my own way. So he stood in the doorway and refused to help. I think that he was seeing what you're probably seeing, Julia, is that I was just giving up. And I think I was worried that, oh, I'm going to hurt them if I keep trying or whatever the case may be. But being encouraging, and this is not a problem that will fix itself at once. It'll take some time. I think if you have a resident that struggles with this, I might even, if you're part of your residency leadership or can put a bug in somebody's ear who is, about having other faculty also help encourage them in this way. That way it's not just you, the one time you work with them every few weeks, that they're getting it more frequently and consistently from the other faculty. So that could help.
I think that this is also an opportunity to use your emergency department environment to your advantage. Standing behind curtains so they don't know that you're there, but you are there. Standing outside of the doorway, doing things to kind of gently nudge them to take on more independence and look to you less. Sometimes with their knowledge, some learners may do better with if it happens without their knowledge and they just feel like they're kind of floundering a little bit. That may push them to take on the autonomy.
Someone put in the chat too, just saying, I'm not planning to put gloves on. You've got this. This is your code. I'm not deciding for you. Again, still being present if they need that help.
I've definitely used that phrase, like, I'm not making this decision for you, where I've said like exactly that. Or sometimes if like there is a patient who maybe is like a little more challenging to interact with, I will say like, you like, I don't want you to feel like I'm not supporting you, but you also need to learn how to like have like stickier conversations or have encounters that don't always go pleasantly. And so like I use those as kind of like, I actually like prep them as to be like, this is why I may seem like more distant during this encounter, because I really want you to like have the confidence to do this. Or another way I do it is sometimes I'll ask them, if you were like out moonlighting right now on your own, because our residents can moonlight before graduation. I'll say, if you were moonlighting at X hospital, what would you do if I wasn't here? And then sometimes that gets them to like, forces them more to like make a decision, and I'm like, okay, we're going to do that.
And someone had pointed in there, verbalize my concern, troubleshooting technique. Also, what do you want to do next? What would you do if I wasn't here? I think our time is up. So thank you, everybody, as Dana put in the chat. Thank you for this discussion. And I have my email in there. If people need like a phone a friend and hey, I had this situation. I'm usually not too shy about sharing my opinion on things. Just ask some of the residents that are on. But thank you, everybody.